There's going to be a panel discussion. Garrison, come on up to the stage too. These chairs look more comfortable anyway. Next speaker, another dimension of direct primary care, and it's kind of an interesting one. One of the things that has been brought to our attention is today we have a number of health systems, believe it or not, that are starting to explore direct primary care. And I think that many would just assume, I assume, that maybe that's kind of an oxymoron, right? But we're all, as a healthcare system, we are trying to figure out how to get to the future. I think health systems are trying to do that too. Their business models are not necessarily as sound as they think about the next 10 to 20 years either. Our next physician is Dr. Ben Aiken. Ben is a direct primary care physician that founded a clinic called Avenue Health. That's actually part of Mission Health in Asheville, North Carolina. I thought it was important to not just have the independent practice and the independent community here represented, but actually get the perspective from this interesting initiative from a very forward-thinking health system about what direct primary care is and how it might be able to be embraced in that context. So with that, Dr. Ben Aiken.
Okay. All right. Everybody hear me okay? Great. Good morning. First off, I just want to say thanks for the opportunity to the HINT team, especially to be able to speak with you today and share a little bit about my story. I also want to thank them for bringing us all together in a space where we can connect with each other, share, and help to drive this movement forward and try to change healthcare in this country, which we so desperately need. Before I dive into things, I'm the son of an architect, and so I'm just going to ask everybody to look up at the ceiling in this room. Take 15 seconds, just look straight up at the ceiling. And as we think about kind of trying to be the architects of the future system of healthcare, think about the intricacy of what this room represents. It's really powerful. It's named after an incredible architect, Julian Morgan. So just a quick shout out there. Okay, so I'll dive in. So about a year and a half ago, this interesting opportunity came my way. So the local healthcare system in my community of Asheville, North Carolina, came to me and they asked me to come on board and to help them create and design a new primary care practice. They were calling it the Innovation Clinic at the time, very generic, and the ask was twofold. They said, take your doctor hat off, put your consumer hat on in every decision that you make, and two, be disruptive, including being disruptive to our own primary care system. Interesting, right? I was not expecting it. Perhaps as many of you in the room, I was kind of caught between, this is exciting, and also being incredibly skeptical as to whether or not they were going to do it. It was a fully integrated health system really willing to push the envelope, particularly in primary care. I spent a couple months trying to vet the opportunity, and ultimately at the end of that, felt like the answer in this case was yes, so I took the plunge. So just to set the stage, Mission Health is the system that I'm referring to. It's the largest nonprofit health system in Western North Carolina. It has a flagship 763-bed hospital, level 2 trauma center, 5 regional hospitals, surgery centers, post-acute care organization, home health organization, many primary care practices, many specialty practices. Annual impact is about $1.75 billion. It's by far the largest employer in the western part of the state. And as far as these things go, it tends to do a pretty good job. So Truven Analytics, which is now IBM Watson, is rated at a top 15 health system for 6 of the last 7 years. But all of these specs that I'm sharing with you really in no way, shape, or form would lead you to direct primary care. So I'm going to talk a little bit about the why and the how, and then kind of give you an update in terms of where we are. So before I ever even took the job, you may have picked up on the fact that I actually didn't say primary care, or direct primary care, DPC, was part of the ask. So the ask was twofold: be consumer-driven and be disruptive. Because of my previous experience, which included a week with Zubin at Turntable as a resident, I had that aha moment. So my leaning from the get-go was DPC. That was my push. Fortunately, I knew before I took the job, the CEO's push was the same, as was the head of innovation. So when I think about the why we were able to pull this off, support from the leadership was key. Those two individuals as well, kind of innovators at heart, entrepreneurial spirit, and so that aspect of their leadership mentality really helped in this way. But with or without their leadership, I would argue that the environment, at least in this health system, but probably in many health systems around the country, is really ripe for this. So at Mission Health 1, they've kind of stated outwardly that primary care really needs to be the foundation of the system moving forward. So as we all know, for Mission Health, as for many systems around the country, primary care is losing money on a yearly basis, and not just some money, a lot of money for the system. So that's certainly one problem. The second is that providers, patients, let's just say everybody is increasingly frustrated with the status quo and really wants to see change. So ultimately, in my opinion, the environment was right for those two reasons. DPC, as many of you know, solves those pain points instantaneously. So for us, okay, so this is good, right? We've got a CEO that's on board. We've got a head of innovation that's on board. I'm driving this forward. We've got a ripe environment for it. But, oh yeah, we're part of this huge, huge cruise ship, which basically has an ineffective steering mechanism. So how are we going to actually get it landed? Then we also have a volunteer community board that we have to answer to, and we have no additional internal support to pull this off. So how do we do it? First thing that we did was we created some separation. We created an entire new C corporation under the health system umbrella in which to live. That really gave us distance from the status quo. Most importantly in that regard, it gave us some legal distance from this overwhelming concern that the system has all these contracts with the payers, and if you're doing this, then you're really disrupting that and you can't do it legally. So it gave us that distance that we needed to be able to pull this off. Second thing that we did, we strategically went basically to each aspect of the system and sought out a specific individual that had innovative leanings. We tried to get them to buy into what we were doing from the get-go and then utilize them to go through the standard mechanisms that existed in the system to get things done. If we had just started by going into that, we would immediately have been said, everybody would have just said, no, you can't go through this. So that getting that buy-in from the internal folks was key. So that's everything from human resources to IT, to facilities, to the pharmacy team, et cetera. We got that buy-in, and then with that team, we pushed things forward. Even then, we still tried to pretty much keep a low profile and fly under the radar. So status quo is hard to change, and so we just kind of slowly but surely kind of did our thing under the radar so that we could actually get to the point where we could pull it off. And then finally, related to that, we created an entire new brand and identity. So, of course, that's the benefit. We're so different from what the health system offers in our community. It's important from a marketing perspective to do that. But as far as the relevance for this room, I think what it allowed us to do was actually to not feel as threatening to the system. So everybody was in the system, they were just like, oh, that's just something different. That's Avenue Health. That's not really Mission Health. So it gave us that space to actually kind of operate and get to the point where we were able to go live with it. So that's the how. In sum, in terms of my own experience with it, I actually had a surprising amount of autonomy to develop this, and that was certainly a positive, and gave us the room to really push the envelope. The other thing was I was surprised to be surrounded by an internal team of folks that were so excited to be change makers. I would argue that every health system in the country probably has a number of people that are part of it that don't feel like they have a voice and they want to be part of seeing change. And if you can find those people within your system, be a huge benefit, and certainly was for me. So in terms of where we are, opened our doors on March 1st. These photos do not look good here, but nonetheless, we have a beautiful space. We went on and built the space out to host 3 providers. We're planning to bring on a second doctor before the end of the year. We were able to do that and spend that upfront cap because we had the access to capital from within the system. That's certainly a positive from my perspective. I would not have done that if I was just doing it on my own. So 3 months in, we've got 78 members. It's about 50-50 in terms of employer versus independent. We are doing, as many of you, a non-traditional marketing campaign, mostly focused on digital. We have an offering through our internal benefits arm to be able to extend out self-insured version of our high deductible plan, self-insured version of that, and match it with us and offer that to employers. Right now, that's only for 50 plus. We're hoping to get that down so that we can engage smaller employers as well. And we are working diligently with a Medicare Advantage offering to have an option for Medicare patients to see us and for us to get paid on a capitated basis with Medicare Advantage starting in January of next year. As I mentioned, certainly the capital backing has been really helpful. So compared to perhaps many people in this room, I really have no personal risk at stake by doing this. I'm a salaried physician. On the other side of that, if we're very successful, there's really kind of no part of that I may be able to be a part of. So we are working to try to figure out if there's a way for myself and for my staff to actually buy in so that we have an ownership stake and actually can reap the rewards if we are successful at this. And I would say compared to probably if I was doing this on my own, I think there's probably a notably ramped up amount of pressure on growth and kind of how fast that's going to happen because we're part of a system. So that's certainly something that we're going to try to navigate. And then also the system, just by nature, on a daily basis, I find myself having to remind people of why we're doing this and how we're different, because ultimately that status quo just starts to creep back in. And so basically the system tries to kind of pull us back to be more system-like, and that really happens on a daily basis. So we have to be very vigilant to stay and keep that distance in that regard. Looking forward, if we're successful, our vision is certainly regional, perhaps beyond. We would have the opportunity to bring a lot of colleagues that are in the system already are watching this closely. They want to convert. They're not willing to take the risk on their own, but if we're successful and then we can convert their practice, they would jump on board quickly. I think there's a great opportunity there. I've had people from rural, underserved, far-off communities outside of the Asheville Center that have also said, hey, when are we going to get our avenue? We're ready for it. I hope we're able to succeed on behalf of all those folks. In terms of whether or not we will, time will tell. Thanks.